Hey guys, Woodruff here. Now let's talk about urinary diversions. So compared to urinary catheters where the elimination is still the same, we just need a different port to get the urine out. Urinary diversions are actually changing the structures in the urinary system in order to achieve urination. And so urinary diversions are usually for patients that have cancers, especially if they have intra-abdominal cancers, female cancers, urinary cancers, people that have genetic malformations, people that get strictures or stenosis in their urinary tract, people that have had trauma, or those that get chronic infections. Sometimes we need a different route to get urine out. And I did not intend for that to rhyme. But you will see that on my, never mind, I'm not going to make that joke. I'm going to stop before I make a really bad joke. Okay. So probably one of the most common ones that you're going to hear talked about is what's called an ileal conduit. And what this is where they take, you have your kidneys up here and then you have your ureters. What we do to divert urine is we actually put both of those ureters together, and then we take a segment of intestine. And the reason you're probably like, why are we taking the intestine? The reason we do this is because we need something that has more structure and support to it. The urinary tract is very thin and very flimsy, and so it doesn't stand up well on its own. So we actually take out a part of the bowel and create a stoma to from those two ureters. We take a part of the bowel, connect it to the two ureters, and create a new way for urinary elimination. Now you are going to be continuously leaking urine from this all the time. So you have to have an external appliance. You're going to have really meticulous care. You need to watch closely. One downside anytime we're taking out part of the bowels is that there is risk for, bowel issues and stuff like that. And I think your book talks about that because, urine is caustic. When it rubs against the bowels, it can create mucus. They can have like more mucus with these. So we do encourage them to have good fluid intake. The mucus is not a bad thing. It's just a natural reaction in that stoma from the urine coming in touch with the bowel. And so just encouraging the client to, increase their fluids to flush out that extra mucus. There's also continent pouches, and these, these are like an ileal conduit, but what we do is instead of the ureters connecting directly to the stoma, they create an internal pouch, and there's different ones. There's a Coke pouch, there's an Indiana pouch, there's a variety of them. You do not have to know those in depth, but just know like instead of having like just a continuous drain that goes straight outside, where again, you're gonna have that continuous drainage of your urine, they create a pouch, and then so that way you don't have to have a bag on the outside. And then what you do is you stick a catheter in and drain that pouch every 4 to 6 hours. So it's kind of almost like making a new bladder. So there's no leaking with this, etc. They do use segments of bowel to create the pouch. So again, we're going to have less bowel. We could have bowel issues. They can end up with bowel complications, but it's just something to consider. But this is a continent, like a way to not have to have the outside bag, continual drainage, that kind of stuff. Your book doesn't talk about this as much. They're actually getting into, they started talking about like this neo bladder that I don't know that much about, where they kind of construct a new bladder and stuff like that. I haven't seen a whole lot of those, but I'm sure that they're up and coming and we'll be talking about them soon. I'm sure I'll have some sort of updated video maybe the next time I have to update my PowerPoints. But one that we don't use as often, but it's still possible, is what's called a cutaneous urethraostomy. And this is where we have the ureters themselves, remember, thin and flimsy. They're made into 1 or 2 stomas. The thing, remember, I told you about the urinary tract, it's very thin and flimsy, so there's a very high risk of stenosis. So sometimes people that get these ureterostomies may end up needing dilations where you have to go in and reopen or help to dilate those stomas pretty much to keep them patent. In other words, they're really high risk for obstruction. So just something to keep in mind that you're getting regular flow from these if you get these. So in other words, there's no bowel use for this one. They just take the urinary tract and make a stoma on the outside. 1 or 2. There's also a nephrostomy, and what this is it's a tube directly inserted into the pelvis of the kidneys, either one or both. There's no need for surgery, but this is something that's not you inserted in you, so there's high risk of infection. It can also lead to stones, and we have to change it out monthly. So this is not something that's used routinely. You're going to see a lot. It's just for certain people, certain conditions. It's usually temporary, so we can get something more established and set up. So possible complications, post-operatively, they're going to be more risk for blood clots. They're also higher risk for urinary tract infections. Some of the devices are going to be, or some of the diversions are going to be at risk for stenosis or obstruction. And then also, like I mentioned, a general risk for infection, not just urinary tract infections, but infection in general. And then I didn't list it here, but skin breakdown as well. So what's my role as the nurse for these? I want to make sure the patient's being seen by a wound care and ostomy nurse. I think I always say that backwards. Wound ostomy care nurse maybe is what it's supposed to be. But it's hopefully if anyone's on here and is a wound WOCN and I'm calling you a WCON that you're not taking offensively. I love what you do. But anyway, we're going to support the emotional transition, especially if they have to have a stoma on the outside. It can be a very big transition for them, kind of like with colostomies and ileostomies, like we talked about. So just supporting the patient, monitoring their intake and output closely to make sure that it's adequate. Like I mentioned before, we want to flush and keep things very patent. So we want to encourage fluid intake. They have to learn how to care for the diversion. We usually tell them to change their pouch every 3 to 4 days or as needed. Good hygiene and meticulous skin care is so key for these patients. I think that's it. That's it. Now we're getting into the big three: UTIs, kidney stones, and BPH. See you for the next one.